مساء الخير, good evening everyone. My name is Hassan Maghaireh. أنا اسمي دكتور حسان مغايرة, أخصائي زراعة الأسنان, مدرس في جامعة مانشستر. عندي عيادة خاصة بليدز, متخصصة بزراعة الأسنان. أنا كتير سعيد إني أكون معاكم اليوم ضمن البرنامج العلمي اللي مقدم من Dentistry Online Facebook Group. وحابب أشكر زميلي دكتور مازن للجهود الرائعة في تنظيم هذه الظاهرة العلمية. كان في محاضرات رائعة جدا اليوم وامبارح عن طريق الكونغرس الأونلاين كونغرس اللي عامله الدكتور مازن والجروب اللي معاه في Dentistry Online. Today I'm honored and delighted to be here with you today, and the whole idea إن شاء الله أقدر answer your questions, inquiries about anything to do in implant dentistry. We will try to mainly to focus on cosmetic implant dentistry, لأن كلياتنا عارفين إنه زمان كان challenge whether the implant will work or not. But nowadays we know if you use a good system, most likely the implant will integrate. لكن المشكلة إنه الimplant could integrate in the wrong position. فبالتالي it's all about the pink and the white challenge. That's why we're going to talk about aesthetic implant dentistry, and we're going to try to answer some of your questions about implant dentistry. Please try to send me any questions you like على ال Dentistry Online group, and I'll be more than delighted, or you could send me questions directly to my inbox. I had some questions already, some of them like, do we need antibiotics in implant dentistry? Is there an evidence to support the use of antibiotics in implant dentistry? The studies have suggested that very good random control trials, مثل الستدي المعمولة Professor Marco Esposito, إنه there is a huge and strong need for pre-operative antibiotics. دراسات لقت لما نعطي المريض large dose of antibiotics, personally ممكن تكون 2 gram amoxicillin or 3 gram amoxicillin 1 hour before surgery, it can reduce the risk by 1 to 25. So definitely pre-operative antibiotics is something really important and something can be really useful in implant dentistry. The question is, do we need to give antibiotics after implant dentistry? هلا الدراسات حتى الآن ما أثبتت أو ما قدرت تثبت إنه الأنتيبيوتكس بعد عملية الإمبلانت مفيدة ولا لا. ما عندنا أي strong evidence to suggest or support that post-operative antibiotics in implant dentistry can be helpful or not. However, دراسات تقترح أو there is anecdotal evidence, الopinion بيحكي إنه إذا الإمبلانت if it was a straightforward implant, no guarded bone regeneration, a small flap, maybe we don't need to give antibiotics. But whenever you raise a big flap and you do guarded bone regeneration or the surgery takes longer time, then it is better to give post-operative antibiotics. فهذا الموضوع to summarize, pre-operative antibiotics كتير مهم, post-operative antibiotics, there is a debate about it. في سؤال إجاني عن البيسفوسفونيتس. What do we do with patients on bisphosphonates? Definitely we know that whenever we place a dental implant in the bone, it's about inducing a trauma. So basically we drill in the bone, we traumatize the bone, and then we expect this traumatized bone to heal around our dental implant. So we want everything to work really well. The first stimulants for the bone to heal around our dental implant is basically أول شغلة بتصير إنه we traumatize the bone, we stimulate osteoclasts. Osteoclasts come over, remove the old necrotic bone, and then they send stimuli to the osteoblast. Osteoblasts start to build bone on the dental implant. لما يكون المريض, when patients have bisphosphonates, our osteoclasts going to be very lazy. Osteoclasts going to be really, really lazy. That's why when osteoclasts are lazy, they're not going to work well. فبالتالي بصير في عندنا necrotic bone, rather than having bone remodeling, it will be slow there, it will stay there, and then we get infection. That's why bisphosphonates can be a problem in implant dentistry. Now, you might ask why us dentists see bisphosphonate issues more than anyone else. Because the bone in the alveolar ridge remodels much, much quicker than any other bone. So, bisphosphonates slows down the remodeling, and we need remodeling after extraction, we need remodeling after implant, so we'll have a gap in the middle when there is infection. To summarize, you need to ask your patient, usually the typical scenario, a lady in her 60s with osteoporosis. You say, are you taking any medications? Are you taking on bisphosphonates? Are you taking any bisphosphonates? And if the answer yes, I've taken bisphosphonates, or I am taking bisphosphonates, the second question is, are you taking them as tablets or injections? And that's a huge difference. The guidelines I'm following personally are guidelines suggested by the Association of Dental Implantology in the United Kingdom. They say, if the patient is on oral bisphosphonates, then the risk is small. There is a risk, but it's small. If patient is taking intravenous injection bisphosphonates, or even if they have taken them in the past, they can be in the high risk. So, anyone who's taken intravenous bisphosphonates, you better say, sorry, I cannot place an implant for you. Go to the hospital, because in the hospital they're going to give them intravenous antibiotics before, intravenous afterwards, and it's a completely different story. But in my dental practice, I don't want to touch any patient being on intravenous bisphosphonates. Okay, what about oral bisphosphonates? Oral bisphosphonates, you have to ask for how long they've been taking them. If they've been taking them for 2-3 years or less, then there's little risk, and usually if you give them antibiotics before, tablets, mouthwash before, mouthwash after, antibiotics after, do very small surgery, try to not do big flaps, make it simple, make it quick, they're going to be working really well. However, if they've been taking bisphosphonates for longer than 3 years, then there might be higher risk. Now the problem is that, is there a blood test we can do to check bisphosphonates level? The issue is, till this moment, there isn't any one reliable blood test to check. Because you might take a blood test, and this will check how much bisphosphonates we have in the blood, but it will not check how much bisphosphonates we have in the bone. And if we have bisphosphonates in the bone, it's going to make our osteoclast very lazy, and then we get necrosis. So it is really important question when you want to check your medical history of your patient to check, do they take bisphosphonates? Have they taken bisphosphonates in the past? And have they been oral or intravenous, and for how long? All right, I think I've got another question. Someone talking about immediate loading and timing of loading dental implants. This is an important topic, and I was lucky to be involved in some evidence-based research, random control trials, systematic reviews done with the Cochrane. What we found that you could do immediate loading. You can load the dental implant immediately, place the dental implant, and put the temporary crown and the temporary tooth immediately in the same session, providing that the implant is placed in the correct position within the prosthetic envelope, and you manage to get a torque of 35 Newton-centimeter or higher. The risk is, if you place your dental implant at a torque less than 35 Newton-centimeter, and you loaded the dental implant, this micro movement going to initiate fibro integration rather than osseointegration. That's why the threshold is, according to so many studies, 35 Newton-centimeter. Now, what if we cannot do immediate loading? The question is, what do we do afterwards? Do we go for early placement, early loading, or delayed loading? Again, the evidence-based studies suggested that if you cannot do immediate loading, you better wait for delayed loading. Give it about 8 to 10 weeks, depends on what you want to do. But definitely you should avoid early loading, because early loading, which means 3 to 5 weeks after placement, this is the most critical time to load the dental implant. So, to summarize, the safest you can do is delayed loading. This is the most predictable way of placing dental implants or restoring dental implants. If you don't want to do delayed loading, you want to fast track your treatment, try to aim for immediate loading. And the most dangerous thing you can do in implant dentistry is to do early loading. That's when there will be very little mechanical interaction and very little biological integration. So you get stability at the lowest level. This is when you need to avoid loading your dental implants. Okay, another question I have, short implants. How safe is short implant? It's a short implant. Now, it's funny because, as you know, implant dentistry changed rapidly and quickly. About 10 years ago, I think you'll find very few people who would like to go ahead, say this is a short implant. About 10 years ago, very little people would like to go ahead and place short dental implants. But Marco Esposito and his group, in the early 2000 actually, they did a very good study where they compared short implants underneath the sinus in one side with sinus graft and long implants on the other side. So it was random control trial, split mouth design, so نفس المريض حطوا له short implant one side, longer implant sinus graft on the other side. And they had a 5-year follow-up. And David, size doesn't matter. Yes, exactly. So the studies have found that they had the same follow-up, whether it's short implants or longer implants. Now, from finite element analysis studies, they found that actually, when you place a dental implant, 1 year after integration, the coronal 6 mm of the dental implant does most of the work. So to be honest, 1 year after integration, most of the load of the stress going to be on the 6 mm coronally of the implant. Anything 10, 12, 14, 16 is definitely not going to be useful. That's why nowadays, if you check my stock, and Katie, my nurse, is there as well, she can tell you we rarely use anything longer than 10 millimeters. We only use 14 millimeter implants when we do immediate placement or we want to do like immediate loading, high stability. But in normal cases, I would definitely aim for something around 8 or 10 millimeter. Now, Straumann has introduced 4 millimeter implants. Saeed, this is the answer for your question. And they say you could place them, especially to avoid cantilevers, but you have to splint them with another implant. You cannot just place 4 millimeter implant on its own. I'd rather place a 4 millimeter implant next to a longer implant rather than having a cantilever. Okay, another question I'm having, let's see, any more questions? Let's see, I have to go through the video and see your questions. When should the last dose of bisphosphonates? Okay, Samah, we talked about bisphosphonates. Basically, if the patient has taken intravenous, even if it's once or twice in their life, as far as I know, that still classify them as high dose. Orally, if they've taken the problem with bisphosphonates, it stays in the system. So even if they've taken oral bisphosphonates 3 years ago, they will still classify them as high risk. Orally, you could still go ahead, but you have to be careful. Okay, let's see. What's your opinion about bicortical dental implants? To be honest, I have very little experience in bicortical dental implants, so I cannot comment on this. I have no knowledge or experience, but one message here, as we teach in Bird Academy, it's everything we do for our patients has to be evidence-based. You need to remember that our friends in dental implant companies, their target is to sell dental implants. And to sell dental implants, they usually come to you and say, this is a unique new dental implant, please try it, it's amazing. And they come out with theories, which might be right, might be wrong. The message here, my friend, is to go to this dental implant company or someone selling you bone graft and say, do we have a clinical study done on patients which prove that this product works? And ideally, it has to be random controlled trial, because you know, case reports are very useful to show a disease, to show something rare, to show a complication. But I wouldn't rely on case reports to promote a technique or to promote a system. So whenever you're in dilemma, try to look for an evidence-based answer. Go to these salespeople and say, thank you very much for your offer. Could you please send me a summary of the clinical studies done on this product before you start to buy and do things. Okay, let's see some more questions. Too many comments. Thank you everyone for your kind comments. I have a question here on Warfarin in dental implants. Warfarin doesn't stop me placing dental implants. The usual, I would ask my patients to check their INR results, usually 24, 48 hours maximum before the implant surgery, and ask them what's the target. If they're 3.5 or less, 4.0 or less, I'm happy to go ahead and place my dental implant, even for patients on Warfarin. However, I don't know whether it's good for us or bad for us. Nowadays, we start to see patients who usually need Warfarin, but they start to take other medications, such as apixaban. The problem with these medications, you cannot take blood tests to check the level. There is no INR working for these medications, so you have to communicate with the GP. I had a patient the other day, and the message was from the GP, just stop these medications 2 days before, and then 2 days afterwards. But definitely this is something the GP has to decide, and not the patient. As for the Warfarin, in fact, when you raise a flap, place a dental implant, you're going to suture the flap really well afterwards. So most likely you're going to be safe. Okay, let's see if you have any more questions. I'm going to refresh the page and check if we have any more questions from my colleagues. I'm so delighted because I can see colleagues joining us from the Middle East, colleagues joining us from the UK, from America. Hello, Alan. So yeah, I hope it's going well, guys. Let's see. Any more questions? Let's talk about guided bone regeneration, and let's talk about ridge preservation. This is a very important question. I keep getting this. Does ridge preservation work? Do we really need, when we take a tooth out, do we really need to pack the socket with some bone? Or is it better to leave it as a blood clot? Or is it better to go for immediate implant? Okay, let's start from the very beginning. My personal view, and this is completely personal opinion, I would personally prefer avoid immediate implant placement. I've learned the hard time. When I started my career, I thought I'm a surgeon, I could do implant, and I could do immediate implant placement. And with time, I start to notice most of my immediate implant placement are the one giving me trouble more than the others. The problem we know, the moment you take your tooth out, you're going to have labial bone loss, regardless, whether you put diamond, whether you put implant, whether you put titanium, bone, you're going to have labial bone loss due to the bundle bone theory. Now the problem, if you're going to place an implant immediately, personally I prefer to place the implant as palatal as possible, put some bone graft inside the socket, and then if the labial plate is very thin, I would also raise the flap and put some bone outside to maintain my convexity. Now what about ridge preservation? Ridge preservation is a treatment option I would consider if the patient comes to me and they say, Hassan, I need a tooth out today, but I cannot have an implant within the next 8 weeks. It has to be 6 months down the line, or patient wants to save up, or they're traveling. So rather than leave the socket empty for 6 months time, this is when I will do ridge preservation. Now another question, right, we're going to go for ridge preservation. What sort of material to put inside the socket? And then you need, my personal opinion and my understanding, you need to decide on the material according to your implant placement time. If you're planning to place a dental implant within the next 16 weeks, I would definitely go for allograft, something human tissue bank such as Maghaireh from Botis. And the reason being, because we know allograft tends to remodel quickly, so it will give you human tissue bone quicker, but then if you leave it too long, you're going to have some sort of bone loss. So the stability of the allograft is not great. So it's okay for 16 weeks. But if the patient going to wait for a year or 9 months time, then I will go for xenograft. Because xenograft, you get good stability on the long term, but very slow remodeling. So if you put xenograft and come back after 4 or 6 months time, most likely you're going to find xenograft. Well, if you leave it longer time, maybe a year or 9 months time, most likely you're going to find some human tissue within the xenograft. So according to your re-entry time, you decide when to go for what material you use in the ridge preservation for your bone graft material. Now, what I would personally prefer though, if I'm going to have a tooth removed, definitely, and this is evidence-based opinion, is to try to aim for early placement. Early placement, you get the safest, you get the least complications. You know that any bacteria, any germs going to be completely gone, so you're not going to reactivate that. You're going, and this is really important, you're going to get extra keratinized mucosa as a gift from the sky. So your flap management will be easier. So that's why I prefer to leave it, after taking a tooth out, I'd rather leave it for about 8 weeks in the anterior region and personally 12 weeks in the posterior region. And then it will be straightforward, easy, most importantly, predictable implant treatment. So this is what I will do. The message here, try as much as you can, avoid immediate placement unless you're very highly skilled and you know that the implant needs to be placed as palatal as possible within the socket, within the prosthetic envelope, and then you need to fill the labial gap. And in most cases, in my hands, I find myself needing to do GBR outside. Otherwise, if I don't do GBR outside the labial plate, which means immediate placement without raising a flap, it will work, but come after a year or two, you're going to find that convexity completely gone. And in aesthetic implant dentistry, it's all about the convexity. That's why this is what I personally would do. Let's see, any more questions? Right, thank you again. People complimenting, people saying thank you. That's great. But let's see if we have some more questions. Right, actually this is fun. I'm enjoying it, guys. I hope you're enjoying it as well. Okay, I have another question in my inbox. Okay. The size of dental implants, the diameter of dental implants. And then we're going to talk about sutures. So what you suture in socket without any graft. We're going to talk about that. Okay. But first, let's talk about the diameter of dental implants. Studies have suggested, from a mechanical point of view, the wider the implant, the better stability you get from mechanical point of view. However, and also it shows that the wider the implant, the less stress you're going to distribute to the surrounding ridge. Okay, so ideally from that point of view, from a mechanical point of view, we should go for the widest implant, the biggest implant we can. But in implant dentistry, it's a multifactorial thing, as we all know. So we need to take mechanics, but also we need to take biology in consideration. And from a biological point of view, we all know that we need a minimum of 2 millimeter bone frame surrounding our dental implant. So when you want to make a decision at which implant diameter I need to use for this case, you need to balance between mechanics and biology. Do a mechanical and biological decisions, integrate them together. So the way I summarize it, use the widest implant biology will allow you. Because what we don't want is to use a very big fat dental implant, destroy much more bone, and then finding ourselves very little labial bone, or even there is no bone to build outside my dental implant. So the decision is, yes, use the widest implant, biology will allow you. And this is based on very interesting studies done showing that when the implant diameter go from 3.5 to 5.5 or 6 millimeter, we're going to reduce the stress from the implant to the surrounding bone by 60%. But the same studies done showing how much stress we reduce going from 17 millimeter implant to, let's say, 6 millimeter implant, they found only 8% reduction. So definitely I would do a shorter implant, but as wide as biology allow me. Now the scenario here, what if I am placing a lower 6 implant and then you take your x-rays, cone beam CT scan, periapical x-ray with a ball bearing, you measured, and you found 14 millimeter bone above your ID nerve. Now we know that we need to have a minimum of 2 millimeter band above the ID nerve. This is the minimum. So I have 14, 2 millimeter band, then you could say, well, why not place 12 millimeter implant? But to be honest, I would go for 8 millimeter implant. And that's all about always having plan B ready. Because if you place an 8 millimeter implant and this implant fails for one reason or another, now, next year or after 10 years, you're going to remove this dental implant and you still have some bone below that 8 millimeter socket to place a longer dental implant. Well, if you, from the very beginning, you placed a 12 millimeter implant, that failed, then you will have very little space to play with to place a longer implant in that scenario. So, the message here, dentists and patients, they need to understand that implants are not for life. They need to understand that sooner or later, this implant going to fail. It could be 10 years, 20 years, 50 years. It's going to fail. And we should always prepare our patients for plan B. They should always be ready that there will be regular maintenance needed, and one day this implant will need to be removed and replaced by another implant. And it's for us, we should always try to think, how can we make it easy for us to replace this failing dental implant? And this takes me to, why do I prefer screw retained? Because over cement retained. Obviously, we all know about the cement and the risk of peri-implantitis, and we're all aware of that study showing that in some scenarios, up to 80% of peri-implantitis was to do with excess cement. Now, this is something we know, but also it's all about retrievability. How many times I've been placing implants for more than 10 years? How many times it happened to me? Something happens, the crown breaks, the abutment breaks. With cement retained crowns, it's nightmare to remove it. While with screw retained, it's all easy to remove. You unscrew and then easy job to sort out. Right, what would you suture if you don't raise the flap? You mean above the graft? Again, if I'm going to do ridge preservation, I will graft the socket or the ridge, and then I would personally prefer to do a soft tissue graft. I would trophine soft tissue graft easily from the upper 8 region. It has retromolar region. Usually it has a thick connective tissue. I will de-epithelize the soft tissue from the margins and then make it like a circle and then stitch on the top. By doing this, I will get the best quality keratinized mucosa. If this is not available, you could use, in Botis, they do mucoderm, and you could raise the flap gently, labially, raise the flap gently, palatally, and put a little piece of mucoderm, stitch it from both sides, even by leaving it exposed. In my hands, I found within 2 weeks, I get really nice keratinized mucosa on top of my mucoderm, but it's going to be really thick keratinized mucosa. So this is what I will personally do. Right, any other questions? Let's have a look. We're halfway through it. Thank you everyone, thank you Ala, thank you David, thank you May, thank you Huda, thank you everyone with your kind compliments. Victoria, thank you. Let's see, any more questions coming? Will you please answer my question? Soma Rashid, please, I've missed your question. Post it back if you can, please. I've missed your question, Soma, but if you post it now, I will definitely try to answer it for you. Okay, number of implants. Numbers of implant from Huda. Numbers of implant, I take it you're talking about full arch, Huda? Okay, definitely nowadays, the message is you don't need so many dental implants for a full arch case. You could do all in 4, and this works really well, has been proved by so many researchers. But personally, I'd like to use 6 implants. Definitely gone the days when we used to do 10 and 12. And the way I explain it to my patient, imagine having a piece of wood, putting too many screws next to each other, it will break the wood in between. You need to have the implants far away from each other, so you have thicker bone around them, and then you get better bone supply to the bone. You need to remember that we need to have minimum of 2 millimeter bone around the dental implant, because the wider the bone, the better blood supply, the higher the vertical bone will be there. Ahmed, this says, in case we place implant in 2 months, do we still need ridge preservation, and what type of bone? Ahmed, no. If you want to place a dental implant after 8 weeks, you don't need to do ridge preservation at all, because in 8 weeks you can go in and you just place an implant with GBR. Soma, what do you think about implant procedure with final restoration done within 3 days? Don't you think it's too fast? Okay, this is immediate loading, which is okay in certain scenarios if you stick to the guidelines, but then it has to be a temporary, because the soft tissue takes good 4 to 6 months to mature completely. So if you put your final restoration in 3 days, and I've seen it, people go somewhere else, they go and visit other countries where implant dentistry is cheaper, so they have the implant, they have the crown done in 3 weeks. Come after 4 months, you start to get some soft tissue recession, metal margins, completely unreliable, unpredictable. The way I do it, you place a dental implant. If you want to do immediate loading, definitely temporary crown, and we're going to talk about the temporary crown shortly, the ideal design of temporary crown or temporary bridge, and then after that, you wait for the soft tissue to mature completely, and after the soft tissue mature completely, you take the final impression. Mazel, what is your opinion about bioimplant? Bioimplant, to be honest, I don't know what bioimplant means. That's the problem we have. We have so many companies, each company calling their implants some fancy names: bioimplant, bicortical implant, the golden implant, the titanium super implant. I don't know. The question gonna be to this company: do you have any clinical studies supporting that this is a good system? Do you have a good follow-up? I think when it comes to implant dentistry, I don't want my patients to be guinea pigs for this company. I'd rather wait and get the clinical evidence before I start using the system. To be honest, it happened to me. When I started implant dentistry, when a company approached me, they were new, they gave me implants free of charge, and they said, please use these implants free of charge. And I placed them, and I'm really regretting that, because one of these 10 free of charge implants has broke now. And I went to the company, there is no proper evidence, no proper communication, so now I have to solve it out myself. The lesson I've learned in the hard way: definitely don't trust these new companies with new names until they provide the clinical evidence. The moment they provide clinical evidence, then you can trust them, you can start using them for your patients. But yeah, definitely I wouldn't like to be someone testing. Samir, treatment of peri-implantitis. Okay, Samir, this is $1 million question, and believe it or not, Samir, till this moment, there is no one on this earth who can come to you and they say, this is the golden way of treating peri-implantitis. There are different theories, different ways, different suggestions. But let's go back one step. Why did it happen? Peri-implantitis is an inflammatory product which causes bone loss and bone destruction. So it's all about prevention. We have to prevent peri-implantitis, and we play a major role, the dentist. In the treatment planning visit, you have to select your patient really well. You need to remember that patients who lost their teeth due to gum disease, they're going to be at higher risk of peri-implantitis. And this is a question I usually find myself needing to ask patients who come to me with dentures, full dentures. And then you need to go and say, Mr. Patient, why did you lose your teeth? Did you lose your teeth due to bridge failure, or did you lose your teeth due to gum disease? And if they did lose their teeth due to gum disease, then you need to think, do I really want to give them a fixed full arch bridge? They couldn't clean around their natural teeth. How would they clean around a fixed bridge? With dental implants, which doesn't have peridental ligaments and doesn't have a smooth surface. So definitely peri-implantitis is something you avoid rather than try to treat. These people who lost their teeth due to gum disease, I try to push them towards having an implant over denture, because then they can click the denture out and then they can clean the implants easily and then put the denture back. And nowadays we can do very good implant over denture. You could even put porcelain teeth, but you don't need that because the composite teeth we're using nowadays, they can give us really, really good results. Another question about spaces between implants and natural teeth. Okay, from a horizontal point of view, in order to have this bone staying there for a long time, you need to have a minimum of 3 mm bone between two implants. But you need to have about 1.5 to 2 mm between implant and a tooth. So definitely try to avoid getting too close to the natural tooth or to the other implant. Because when you do that, the bone is going to be very thin, and then the blood supply to this area will be very little. You're going to get recession. They found direct relationship between the width of the bone and the vertical height of the bone on the long term. And now we need to talk about, what about papilla between implants? Papilla between two implants also depends on the width of the bone between the two implants, and also depends on the distance between the crest of the bone and the contact area between the two implants. They found, Salama brothers, they did the studies, and they found that you need a minimum of a maximum of 3.5 millimeter space between the contact point and the crest of the bone to maintain a papilla. Now, the best scenario in implant dentistry is between implant and a pontic. You need around 6 millimeter vertical space between bone and implant and a contact point to get a full papilla. That's why this is a question I usually get asked. In the full arch cases, I try my best not to put implants in the anterior region because it is easier to get papilla between pontics rather than between implants. 6.5 millimeter height between the crest of the bone and the contact points of the two pontics to get a full papilla. So, in the anterior region, in full arch cases, definitely try to avoid placing implants in the anteriors. I would start placing them in the canines backward, definitely not in the anterior. All right, who else? Any more questions? Let's see. I think I've missed some questions. I'm not multitasking. I need to learn how to read questions and answer questions at the same time. So those of you who didn't answer your questions, please kindly feel free to post them again, and I will try to go through the page as well. Let's see. So in the meanwhile, again, I would like to thank Mazen and his nice group, Dentistry Online, for organizing these 2 days online lectures, webinars. It's been really good, different topics. Ala Al-Farra, what's the best material for intracanal irrigation? That's cheeky, Ala. I think you're watching the wrong lecture. You know that I haven't done an implant for the last... You haven't done root canal treatment for the last 12 years. 12 years since I've done my last root canal treatment. But I think from what I've heard from Hamma, was it hydrogen peroxide? I don't know. Corsidil, saline? Well, I don't know. You're watching the wrong lecture, Ala Al-Farra. Okay. Let's see, and what are the risks of placing implants too close to natural teeth? I think, Amal, we answered this question. We said you're going to lose bone, you're going to have a pocket, and this is not right. Okay, thank you. Some more people sending their nice comments, encouragement notes. Let's see what other questions we have. Okay. Any other questions? Let's see. Again, okay. Do you recommend one-piece implant? What's your opinion about tilted abutments? All right, Ahmed. One-piece implants, I think they have their place, definitely, but not in the aesthetic region. Definitely not in the aesthetic region. That's why I prefer, personally, not to use them in the aesthetic region. What about angulated abutment? Now, the thing is, when you place implant in the aesthetic region, you need to make sure that the implant is within the prosthetic envelope. You can get away with 10-degree angulation, but what we don't want is like 25 degrees. Now, one of you might say, well, I'll place my implant 25 degrees in the anterior region, and I'm going to use an angulated abutment to correct this 25 degrees angulation. The problem is, once you start using too much angulation of the abutment, the labial profile of your abutment going to be too bulky. They have to, otherwise it will be very weak and it will break labially. So the lab will have to make it really bulky for you. By making it too bulky, you're going to put too much pressure on the soft tissue and you're going to have recession within the next 6 months after completion. The other thing, once you start using angulated abutment, you're going to find them, due to the correction of the angulation, becoming too short. And once they're too short, they're not going to be very retentive. That's why I would rather place my dental implant within the prosthetic envelope in the correct 4 dimension, even if this is going to give me some perforation apically. I can use my GBR. Okay, Reem, please can you talk about Maryland bridge on implant side during healing stage? Yes, I prefer, whenever I'm waiting for the healing, I don't like dentures. Dentures, they don't give me good soft tissue support, and they can give me bone loss. So what I would rather to do, I would rather use a fixed provisional. And my first choice is to do what we call the rochette. It's basically a Maryland with a composite pontic, but the wing is perforated. And for a single missing tooth, I would rather use a pontic with a single wing, so it stays better. It's perforated. I just bond the palatal surface of the adjacent tooth, flowable composite, that will stick. And because it's perforated, the composite or the Reliax, the cement will just go through the perforations and sandwich the wing for me. And then you could easily remove it and put it back. Implant retained fixed and removal procedure in edentulous. When and what to choose? George, Habibi, this is like a full lecture. Right. One of the things, you get the patient to get involved in this decision-making process. You have a patient with a denture, say, right, let's take the denture out. And I take a picture, lateral profile. And then I show it to the patient, say, this is how you look like without a denture, and this is how you look like with a denture. And most of them, they get surprised that their lip get flat without having the flanges of the denture. That's one decision. Because the moment you find out that they need a flange, definitely you cannot give them a bridge, because how would they clean that bridge with the flange? And this is where dentists can give their patient peri-implantitis. When dentists give their patients prosthesis which is not easy to clean, they're going to induce peri-implantitis. And who to blame? Definitely the dentist. That's why you do that test, and then you talk about the history. Why did the patient lose their teeth? Was it due to gum disease or not? And then you try to sort of steer the patient towards the best prosthesis which suits them. All patients would love to have fixed implant bridges, but are they all suitable for fixed implant bridges? This is the question. So my answer is that you check the facial profile with and without, you check the ability of them to clean, and you check why they've lost their teeth. Okay, is putting implant in the upper lateral place acceptable? Some say no, definitely. I have patients with a missing lateral. You could place a dental implant in the upper lateral, but you need to remember that you need a minimum of 7 millimeter space. Now I'm lucky because the system I use is Straumann, and they have 3.3 millimeter implant. It's made of titanium and zirconia together, so they call it rock solid. So 3.3 millimeter implant is still strong. So that's why I would place a 3.3 millimeter implant, and then I will have my 1.5 on the side. So providing I have 7 millimeter mesodistal space, definitely it's good. You can do it. And yes, Michael, exactly. We placed 2 implants today in the upper laterals, and you did really well, Michael. Jonathan, could you talk using implant to support cantilevers? This is something I start doing frequently. Whenever I do full arch cases, rather than leaving a long cantilever at the back, I'm more than happy to place a 6mm implant at the back, and this will stop cantilevers, definitely. Even with overdentures nowadays, rather than just placing 2 anterior implants, I'd place 2 long anterior implants, okay, and then I would put 6mm implant, 1 on each at the back. And this will stop the denture having the rocking movement. Because you need to remember, when you do an implant over denture, you're having an implant denture retained by the implant, but supported by the soft tissue. And with time, the soft tissue is going to resorb, the ridge going to resorb at the back, and you're going to have this rocking movement. So 2 more short implants at the back, and then your denture going to be retained and supported by these 4 implants. And this is what I do. I prefer to use tissue level implants for overdentures. My technicians love them, and they find them very easy to repair and to restore. So definitely 4 implants for my overdentures. Okay, let's have a look. Let's refresh the page and see if we have any more questions. I know I've missed few questions, but as I mentioned before, all my friends know me. They know that I'm not multitasking, and I cannot read and answer at the same time. Okay, Omar Laqsus, what's the minimum size of an implant in the molar region? Omar, I've answered this question earlier on, but I'm happy to say again, I'm happy with 8mm. That will do the trick. 6mm in certain cases, this will do the trick. Definitely, I don't need 10, 12, or 14 in the molar region. I would prefer to go for something wider if I'm going to achieve the 2mm bone frame. Like 5, something like this. Abdul, if the bite needs to open slightly as they're considering placing implant regarding open bite, with denture, try it. Yes, definitely. Whenever you want to place a dental implant, you need to do reverse treatment planning. Try to think restorative, get everything sorted out, whether the bite needs sorting out, whether the vertical height needs to be sorted, perio needs to be stabilized, and only then, once the patient is medically stable, dentally stable, only then can place a dental implant. Okay, my friend Slav from Bulgaria, implant with tooth in a bridge. Slav, what do you mean, implant with tooth in bridge? Can you re-post your question, my friend? Okay, let's see some more questions. Let's see if we have any more questions. I'm going to refresh the page again. I'm refreshing the pages. Oh, Anas Maghaireh joined. My brother Anas, who head of the computer company in Amman. I'm making an advert for you, Anas. Joined us. We're not talking about computer, Anas. We're talking about implants. Ahmed Eid is asking about connecting tooth to an implant. Ideally, I wouldn't like to connect an implant to a tooth because obviously the mechanics. Implant is fused to bone, tooth has periodontal ligaments. Have I done it before? Yes, in certain scenarios you're pushed to do that, but then you warn the patient. And the best way to do it, you make a telescopic crown on the tooth, and then you cement the bridge to the telescopic crown on the tooth and to the implant, and you tell the patient about the limitations. But yeah, definitely try to avoid that as much as you can, because believe it or not, you're going to cause damage to the tooth rather than the implant. Is it possible, Ahmed Tahbub, is it possible to create an implant retained chrome cobalt partition? Yes, it is. You can. I've done it a couple of times before where patient has free and saddle. I could only place one implant on each side rather than having clasps. I could just put an implant and a Novalock or a locator on one side, and then a denture with very little flanges because you don't need flanges, and then denture housing and clicks. What's the most, Zaid, very good question. Zaid Rocha, what's the most common complication in implant surgery? Zaid, this is a very important question. And believe it or not, the most common complication in implant dentistry is placing dental implant in the wrong position. Placing a dental implant which will integrate in the wrong position is the biggest disaster an implant dentist can do to his patient. Because all what you need to do is place the implant 1 millimeter too mesial or too distal, or place the implant a bit too buccal outside the bony envelope, or too palatal, you're going to get ridge lap, crowns, very difficult to clean. When you place it too labial, you're going to have very little labial bone, you're going to get recession. Or placing the implant in the correct position, but the fourth dimension is wrong. You place the implant in the wrong angulation. And this is what I've been lecturing on recently, is that people get the 3-dimension right, but then they got the 4th dimension wrong, which is the angulation. And then the implant coming out like that, very thin labial plate, implant putting pressure on the thin labial plate, you get resorption 2-3 millimeter. You get that resorption 6 months to 1 year afterwards. And then patient come back and say, why do I have a long clinical crown? Why my implant crown looks ugly? Do you know what's the only treatment? You can't do soft tissue graft. You can't do guided bone regeneration. The only treatment in this case is to remove the implant and start again from 0. Okay, let's see if we have any more questions from our colleagues. Okay, let's see. Do you recommend prescribing vitamin C to diabetic and other medically compromised patient? Okay, let me tell you this something. What's the future of implants, do you think? That's 2 good questions. First of all, do you recommend prescribing VT as a dentist? I don't want to prescribe anything medical to my patients because it's going to be my responsibility. I would rather the GP. Having said that, there is a maxillofacial surgeon. He's one of my mentors. I've learned a lot from him. Professor Sanjit Kreen, who's the Dean of UCLan University. And he used to come and tell me, Hassan, these people who are taking multivitamins and they're healthy, they're just having a very expensive piss. So you don't need multivitamins your body producing everything you need if you're healthy. Now, if you're diabetic, if you're pregnant, this is a different story. But then I would rather the GP doing this. Future of implant dentistry. I know a friend of mine who works, who's working, okay, let's see. A friend of mine who's working in Denmark, they work on stem cells and they are growing teeth. And yeah, I think very soon they're going to be growing teeth. Now, luckily, so far, they're growing them, but not in the right orientation. So they're growing enamel, dentine, pulp, but in a mix. So they're not giving them the right shape. So we still have, I think, another 10 years placing titanium implants, but maybe sometime soon we'll be growing teeth using the stem cells from the pulp of baby teeth. How do you deal with post-operative pain experienced by the patient? You need to find out, Khuzama, why is the patient having the post-operative pain? Is it the normal surgical pain or is it because of infection? So it starts by preparing the patient that, listen, implant surgery is an operation. You're going to have some swelling, you're going to have some bruising, but you have to take antibiotics regularly, painkillers regularly, and you have to use ice packs. Sometimes I give dexamethasone, 8 milligram IM injection helps with the swelling and the bruising. But then I tell them you have to have some pain for a week, controllable with some decent painkillers, ibuprofen 400 milligrams, 4 times a day. But then if they're still in pain, you have to see them. Is there post-discharge? Is there some fluctuant swelling? Is there temperature? Because sometimes it could be infection. Can I place an implant for a pregnant? CT already exists. Tough. I know, because pregnant, ideally we shouldn't be doing any elective treatment for pregnants. Obviously, implant dentistry is an elective surgery. So I would say you have to decide case per case. And should you decide to go ahead, the safest time is in the middle trimester, and the patient needs to be well informed of every single risk. And you have to be careful. What you don't want, God forbid, the baby comes with a complication, and then they say, oh, where's Dr. Raouf? He placed an implant for my pregnant wife or pregnant friend, pregnant sister, and because of him, my patient is not feeling well. So, you know, sometimes it's better to minimize the risk. Do you prefer immediate implant? We talked about this in detail, and I would say definitely immediate implant is more risky. You could do it if you're really highly experienced, but when you place immediate implant, please don't use the biggest implant you have. Go for an implant with a narrower diameter. Go for an implant which you can leave a gap, fill the gap in the labial bone, and put some bone outside as well. You need to protect the dental implant a long time. Mazen, after 4 minutes, Dr. Iyad Ghanem will be live. Definitely, this is a very good lecture to attend. Dr. Iyad, I'm sure his lecture is going to be very useful. Go ahead. And again, Mazen, you're doing a superb job. For you to organize 2 days with online webinars and lectures available for everyone free of charge, you're a star. And I can't wait for the second time you arrange something like this. I can see a lot of patients, uncontrolled diabetic patients having dental implants. Completely wrong. Completely wrong. Diabetic patients, they're going to have a problem with their blood supply. You put an implant in the bone needs to heal. And definitely, diabetic patient is not going to heal very well. The problem, sometimes it works for them by luck once, twice, but eventually one day they're going to regret it. And they're going to regret it with someone will cause them a lot of problems. Whenever you want to practice implant dentistry, the last message, we have 2 minutes. Whenever you want to practice implant dentistry, my friends, please apply the daughter test. Would I do this to my daughter or the sister test? Would I place this dental implant for my sister if she was diabetic and she was not well controlled? Will I place this dental implant for my sister or my daughter without proper planning? And please, you know, try to be honest with yourself and do the best for your patients. It was great having you. And Dr. Nabil Nahas saying, are there any new courses in 2017? Definitely. Bird Academy, as you might know, I'm the head of the scientific committee for Bird Academy. I'm so looking forward to meeting you. We have a series of some advanced courses coming to the Middle East, to Dubai, to Saudi Arabia, Bahrain, Jordan, Egypt. And we will be doing these 2-day courses on guided bone regeneration, soft tissue grafting, immediate loading. So keep following us, keep following our website, www.bird.uk.com, and the Facebook page and my Facebook page as well. We have huge courses, great speakers coming to the UK and to the Middle East. Thank you so much for your time, everyone, to be here with me. I've really enjoyed it. I can't wait for the second session, and I hope you have a great evening. All the best. Take care. Bye-bye.